being said, I'm going to pass the baton back to Brett to do the introductions for today's lecture. Brett?
Okay, thanks, Guillermo. So yes, and I'll pass it off really quickly to Dr. Thrasher, and he will tell a little bit more about who he is. I've heard his presentation in the past, and I love it, and so I'm always learning new things. And so I think you're going to enjoy as much as you can enjoy a topic of opiates in our world, but it's very informational, and I learn something every single time. So with that, Dr. Thrasher, so if you'll hit, if you've opened up your PowerPoint, if you'll hit record at the bottom of your screen, share screen, excuse me, not record, but if you'll hit share screen, it should then allow you to pick, there you go, and then you'll, there you go, perfect.
I think I'm there.
You are there, fantastic, thank you so much.
Good evening, everybody. Thanks for agreeing to spend some of your precious time with us. I'm Dr. Thrasher. I've been back here at Eisenhower for about a little over 10 years now. I say back here at Eisenhower because I grew up here in the desert, and recall immediately after the hospital was open was one of the first patient transport people in the facility. I knew fairly early on I wanted to go into medicine, and while when I left the desert, I didn't think I would ever be coming back. Alas, here I am, and I'm pleased to be a member of the faculty of the Family Medicine Department here at the Argyros Center in La Quinta. It's been a long time interest of mine to be able to treat pain. Pain is one of the most common reasons a patient will go see a doctor, and oftentimes that pain can become quite severe. And then there are some patients that have already had their pain treated, and many of those patients have been put on opiates of various types. And I just sort of made it my personal mission early on to educate myself. That subsequently led to an interest in addiction medicine for those people who may have gone on to develop a problem. I liken it sort of to the obstetrician who's able to go in and do a C-section when a pregnancy becomes troubled. However, starting somebody on buprenorphine, though complex, can be quite a life-saving venture. So the issues I would like to talk to you tonight, I would like to, first of all, thank Clint Eastwood and his colleagues who 30 or 40 years ago filmed the movie The Good, Bad, and the Ugly. When I think of opiates, I think of some of the good that opiates have done. Certainly the bad and the ugly far seem to outweigh what good they've done, but opiates have brought reasonable and responsible relief to a number of people that suffer from chronic pain. However, when those treatments get out of hand, for any one of a number of very good and some not so good reasons, then we have sort of a bigger problem to contend with. So hence the name, The Good, the Bad, and the Ugly. The Federation of State Medical Boards, just to assure you that I'm not an opiophobic physician by any means, that all doctors, and I take this quite serious in my role here as a teacher in the Department of Family Medicine, should be aware that we have a primary responsibility to appropriately treat pain. But in recent years, with the issues surrounding the opiates, it's become important for us to more responsibly deal with treating pain and monitoring our patients as we go along. In recent years, we've all been aware of the influence prescription medicine has had on our patients. And then all of a sudden, those medications are not as readily available as they had been before. And people have turned to injectable forms of opiates, thus leading to sexually transmitted infections or to other deadly virus infections such as HIV/AIDS, as well as hepatitis B and C, and also the destruction of families. So towards the end of my talk, I will talk about how we currently are able to help patients in the family medicine department. And we'll also make a brief mention of the development of the addiction treatment fellowship that is currently underway under the direction of Dr. Eduardo Javier. And their facility will be located in Cathedral City. So I thought we would start with a little bit on how opiates work. Perhaps many of you might have seen a news special or a PBS special, or have picked up an interesting magazine discussing how people think opiates work. This will be a brief interview, certainly, but there are a number of key receptors that are placed strategically throughout the body, and these receptors are known as mu receptor, Greek letter M, delta receptor, and kappa receptor. And they all do, some of them do the same thing in different ways, and then they all have their own individual responsibilities. However, when they get activated by the appearance of opiates, they can begin to do, they work in strange and mysterious ways that prolonged use of opiates can have worked to the detriment of the individual. We all know, of course, that as we experience pain or sensation at the end of our, anywhere on our body for that matter, but in this particular example, by placing our hand over a fire, we have impulses that race up to our brain, tell us that there's a painful or noxious stimuli occurring at our hand, and then a reflex message comes back down that says, let's get our hand out of there. And as this slide indicates, with these specialized nerve endings that can detect temperature, they get transferred biochemically up into the brain, with a reflex message coming down, acting upon the muscles to cause us to remove our hand from that. Down here, we talk about the key areas, the cerebral cortex, that's the peripheral most area of the brain, the limbic system, sort of the interior system of the brain, and that emotional center where when you hit your finger with a hammer, you come out with an Anglo-Saxon expletive, or indeed the frustration of having things fall on you during the course of repairing your patio. You can tell I've had some experience with this. And then, of course, the brainstem, which seems to control a number of automatic functions like breathing and heart rate. And all these are affected by pain. Here's a slightly different diagram that shows us a little more detail to what's going on inside the brain. And here we see where the nerve impulses are conducted up and through into and across the spinal cord. This dorsal horn, as it's called too, this refers to the back of the spinal cord, an area we refer to as the dorsum. And through these little horns, as they're referred to, is where the nerves travel that transmit both afferent, which are messages that go to the brain, and efferent, which are messages that come from the brain to the affected area. And these follow in general up on the lateral aspects of the vertebral column here in an area known as the spinothalamic tract. We also have, as you see here, primary and secondary afferent neurons. These again are the messages that are conducted to the brain, and then the efferent neurons coming down the descendant pathways. So this is a somewhat oversimplified, nonetheless, let you know that we are getting from the hand, the foot, the abdomen, wherever you're having pain, the mouth, immediately into the brain, triggering a number of very sophisticated processes, resulting in a stimulus that we perceive as painful, requiring us to want to seek relief for that pain. Finally, again, looking at a similar type drawing, I pulled this slide out here because it sort of represents these opiate receptors. And when we talk about receptors, these are specific molecules that are shaped to match up with another specific molecule. And as the name would suggest, most opiates, with morphine being a prime example, has a molecular shape for which the receptor is ideally designed to. Because this receptor fits on top of a cell and comes through the cellular membrane, it's connected inside the cell to react and respond by producing a number of other chemicals that might be released. And in this particular case, these would be the other chemicals that would continue to propagate a painful stimulus, but the morphine is able to block it by the changes that occur in the shape of this receptor when the morphine sticks to it. And then likewise, if there's no morphine that sticks to this receptor, then the pain stimulus is allowed to go on. And we have the three basic components of getting a message to the brain, which is transduction, turning a hammer blow into an electrical signal, or a fire, or a pierce, a nail through the hand or foot, transducing that into an electric stimulus that is then transmitted on up to the brain. So you can see here where we have the secondary afferent neurons beginning to travel up. That is the beginning point of where the opioids act. In other words, that is where we start to see these specific opioid receptors in the spinal column. These three receptors that we talked about before, the mu, the delta, and the kappa, have these various responses when they come into contact with a morphine-like substance. And of course, the mu receptor for morphine analgesia, that's the calming down or the quieting down of the noxious stimuli. This changes smooth muscle tone. This facilitates muscles to relax. It can also make us sleepy. It, not surprisingly, alters the mood, and we'll learn a little bit later that this mood alteration occurs as a function of the production of dopamine, which also can create a problem down the road because we want to have that good feeling of the dopamine being released. Can also result in some nausea and vomiting. The location of these mu receptors are in the mesenteric plexus, and this is down in the abdominal region. There are also mu receptors located in the brain and spinal cord and the submucosal plexus. The delta receptors we find mainly in the mesenteric plexus, that's in the abdominal region, as well as the brain. But those in the mesenteric plexus, the delta receptor is the one primarily responsible for causing the decrease in colonic transit time, or more commonly called constipation. You'll know that there's or I'm sure you're aware that there are medications now that we can use that will specifically block the delta receptors, so we can alleviate this constipation that occurs when we are treating patients with opiates who subsequently develop severe constipation. And then finally, there's the kappa receptor, and it is the one responsible for central analgesia, a lot of the really good analgesia that we experience. It too can decrease the colonic transit time. This is also a receptor that were you to be stabbed in the abdomen, or when you have other visceral type pain, that when this is activated, this can help relieve that pain. Not surprisingly, again, found in the mesenteric plexus, the brain, and along the spinal cord. So whenever we talk about opiates and the effects they have, the biochemical underpinnings have to deal with these three primary receptors, mu, kappa, and delta. And these three diagrams here sort of talk about the kappa opioid receptor and the modulation that occurs when it is triggered with a morphine agonist, and which results in the subsequent release of dopamine. And it's that you can imagine that after using opiates for a fairly long period of time, it's a lot like smoking, and that you continue to get that dopamine release. And while the opiates really don't do that much for pain long term, which is why they have fallen out of favor as a primary recommendation for long-term or chronic pain, they do facilitate people feeling better, and hence their continued use beyond their pain treating efficacy. The various types of pain that we deal with are primarily nociceptive. A nociceptive type pain is best described by when you hit your finger with a hammer. Neuropathic pain, which can develop with the development of some chronic diseases, some cancers, you can develop neuropathic pain. Certainly diabetes can result in nerve damage causing neuropathic pain. Then fibromyalgia type pain, it's become its own specific type of pain, usually because the early to mid studies done on fibromyalgia seem to indicate that it was a problem in the production of substance P, and that something was interfering, either a virus, in most cases it's felt to have been a virus that interfered with the body's ability to manage its own pain. I'm sure many of you are aware that the body is able of producing its own endorphins. Endorphin means endogenous morphine. And when that gets interfered with, the things that might cause mild to not even perceptible pain in most people can be a source of major pain to fibromyalgia patients. And in talking about these three types of pain, certainly opiates are probably best used for acute nociceptive pain, perhaps a traumatic amputation or a fractured limb, although you will find most orthopods not recommending opiates for their patients anymore. Neuropathic pain, opiates are not recommended at all. In the case of fibromyalgia, they have, while they were recommended early on by a cohort of fibromyalgia specialists, we are seeing their recommendations sort of fade into the back as well. The chronic pain issues, these are important definitions to keep in mind. When we talk about chronic pain, we're talking about pain that has existed for at least greater than 6 months. Acute pain we refer to as typically less than 6 weeks. And then palliative care, which is pain that comes at the end of life and may be the cause of a malignant cancer, some type of chronic disease that has caused some organ destruction or damage that has created daily pain in a patient. So briefly, that's how opiates work, and a little bit on the definitions that we as physicians use to discuss them. In 2017, with the increase in opiate deaths, as well as an increase in the appearance of HIV/AIDS from opiate injections in the Midwest, mainly Indiana, the CDC published a set of guidelines that they had intended, and I think have been in most cases, implemented in many clinics to provide a structured and sound approach for how we might treat our patients with opiates that have chronic pain, and indeed how we might take care of them if we find their use of the pain medication went out of control. While this data goes to 2017, you can see the significant increase here in the synthetic opioids, and as the caption indicates, other than methadone, had just shot up. And a lot of this had to do, I think, with with the FDA and DEA becoming concerned that they wanted to cut back on the prescription of opioids for pain. This pushed a lot of people out to the streets, and not knowing what they were getting caused an increase in death. The not teased out of here are what percentage of these deaths were IV related versus other contaminants versus accidental overdose. We see here the rates of death due to heroin are really kind of low compared to the synthetic, or could also think of them as the prescription opioids that we use mostly for pain. Finally, here, deaths due to cocaine and natural as well as semi-synthetic opioids. The natural opioids would be codeine and codeine and I forget the other natural one, but they're close together. You can see methamphetamine has kind of fallen here, and methadone deaths have come down. Back here in 2005, 2006, we see a peak, and that peak from about 2004 on up to 2006 coincided with the reports that were coming out saying doctors were not adequately treating chronic pain. And we were being told that methadone was a much safer drug to be using because it gave a more prolonged pain relief response. But what information didn't get out immediately was that there are almost 2 half-lives with methadone. And that is that methadone has a sort of 12 to 18 hour half-life for pain resolution or improvement. And then it has a much longer 24 to 36 hour half-life for potential respiratory depression. So if you figure you took a little and you got a little pain relief, if you took a little more, you were feeling pretty good, but then 24 to 36 hours later, you were paying the piper with the respiratory depression. In any case, as doctors tried to respond to the input that they weren't doing a good job treating pain and going to methadone, we saw a rise in methadone deaths. And so with that rise in methadone deaths, everybody thought, well, maybe methadone isn't the best medicine to be using. We start to see more people thinking that maybe opiates in general are not the best thing to be using for long-term chronic pain. So at that time, it was comforting to see those rates going down, but now we see that methadone is continuing to slide down to these last numbers of 2017. Suffice to say, this particular graph shows that there are a number of bad outcomes using this particular type of medication. These numbers, of course, are not specifically teased out to represent what percentage of these were prescription-related deaths versus deaths from patients on the street. But it's important enough for a physician to know that there's a problem with this particular class of medication and premature death. So with the onset of the publication of CDC guidelines of 2017, there were a couple of key features that were driven home that doctors have since taken as dogma and have attempted to employ in their practice. And these are perhaps the 3 main ones. Trying to determine when to, is this pain that we should really be starting with an opiate and or should we be continuing with that? If we should be continuing, are we with the right medication and the right dosage? And when are we going to stop this? Because the data continues to support the ineffectiveness of these particular medications for long-term chronic pain. And then finally, training doctors to be aware of and how to assess for the risks of harm that can come to patients when using this type of medication for this chronic pain. As we've been taught now, we don't reach for hydrocodone, used to be Vicodin. We no longer reach for that first. That should not be first line, nor should it become routine therapy. So anybody who comes in and you're thinking of giving an opiate to, And as you may have seen with many pharmacies, the insurance companies have now said, hey, if this is a first-time prescription, then we're only going to honor this for we're only going to give you 7 days. And indeed, I've seen this with patients who leave here and come back, and then I write them their prescription when they're back here in the desert, and they go to the pharmacy, and the pharmacy says, I'll only fill this for 7 days because we haven't seen you in 6 months. The other thing is to establish goals for what the patient can expect from you, the physician, with regard to what you're willing to do to treat their pain, and what the patient should expect from that. Certainly some patients expect that their pain can only be treated by opioids, and if you're not going to, or you're only willing to go so far, then they might at that point say, you know, I think I should probably just go to a pain management specialist. That's fine, but primary care doctors should be able to take care of most first-line pain, and we would hope to be able to find perhaps a mixture of lower doses of opiates than we've used in the past, along with other modalities to treat pain. Finally, doctors have become more aware of the benefits and risks of the benefits and risk of non-opioid therapies that we can use with the patients. And so this is a summary of the various things that we put to work in our practices. Certainly the cures in California, that's a report that tells us every time a patient gets a Schedule C drug. Using urine drug testing more often in the doctor's office. Also trying to avoid benzodiazepines, never prescribing soma together, and trying to significantly reduce sedative hypnotics such as Ambien concomitantly with opiates. Ideally, this is kind of a busy slide, but we would like to be able to, when patients approach us with pain, determine their amount of disability, the source of their pain, with a feeling of, gee, my guess is this pain's going to last 3 days, 6 days, 12 days. I think you're stuck with this for life, and then beginning treatment accordingly. And so this would be a conservative approach to beginning to treat pain as it arrives. Interestingly enough, if we look at a collection of medications that, when studied and compared to morphine's the pain med down here in the orange, we see this number needed to treat, and number needed to treat is derived from typically randomized controlled clinical trials with reasonably decent statistics. And this says how many patients you would have to treat with this drug over a given period of time to affect the same pain control that you could expect from any other type of medication. And so in this case, we can look at morphine and say, well, the number to treat is 2.5 people. But here, and these are two COX-2 inhibitors. Here's celecoxib that we sell in this country. Oops, sorry about that. You can see that it takes fewer people, almost a whole one less person, before we actually affect good pain management before we get to morphine. Likewise, Tylenol with codeine. Certainly the expectation is that, doc, if you give me codeine, I know I'm going to be great, and I know that my pain is not going to bother me, and I'll be able to get done those things I need to get done. But we also need to consider the risk versus the reward. So not that there are not risks with the COX-2, certainly, and not that there aren't risks with the codeine and Tylenol, but you can see that there are some other choices available to us before we have to dip down here into the morphine. Oddly enough, tramadol, which has been a major go-to for a lot of doctors, you can see that the number needed to treat is really a little higher than most, at almost 4 patients. So you would have to treat 4 patients to have 1 patient feel comfortable, whereas up here with celecoxib, really slightly less than, you would have to treat slightly less than 2 people to have one of those people feel comfortable. I think I would argue for celecoxib over the tramadol and even over the morphine. So I thought that was an interesting piece of information to toss out to you. Also, as doctors look at giving opiates now, since there are different types of opiate-based medication, there's Dilaudid, there's fentanyl, et cetera, we turn everything to morphine milligram equivalents because we figure everybody's most comfortable with thinking in terms of morphine. If you say, gee, somebody's getting morphine for their pain, oh, it must be really bad. How much are they getting? Are they getting 5 milligrams? Are they getting 20 milligrams? Are they getting 50? And so there's this conversion factor that, for instance, for hydrocodone, if I give you 10 milligrams of hydrocodone, what is the morphine milligram equivalence? Well, hydrocodone and morphine are 1-to-1, so 10 milligrams of hydrocodone is the equivalent of 10 milligrams of morphine. Hydromorphone is 4, Dilaudid. So if I give you 2 milligrams of Dilaudid, I'm actually giving you 8 morphine milligram equivalents of morphine. Down here, morphine, of course, is 1-to-1. Oxycodone, which is our Percocet, and also Oxycontin, you see is 1.5. So if I give somebody 10 milligrams of oxycodone, that's the same as 15 milligrams of morphine. So when we see our patients now, we always think in terms of morphine milligram equivalents. This is also a conversion we do if we're thinking of changing your medication to something else, to ensure that we're going to safely cover your pain and not inadvertently overdose you or underdose you as we transition to other pain modalities. This is again derived from some fairly good statistics on the amount of overdose events that occur, and these odds ratios that we deal with statistically, any number greater than 1 is significant. So you can see when we talk in terms of morphine milligram equivalents in the range of 20 to 49, there's a significant increase in overdose deaths that occurs, this is overdose events, and here we have overdose deaths. Likewise, when you go from 50 to 99, there's a significant increase in events and an even greater increase in deaths. And from greater than 100, we see the numbers continue to rise concomitantly. So increasing the amount of morphine a patient takes puts them at risk for unintentional overdose. And potentially death is pretty well documented. This also coincides, these numbers here coincide with the increase in risk. For instance, patients that are on morphine, when they hit the 50 morphine milligram equivalents per day, that is where the first significant bump in risk occurs. And so that's where we would call out this 1.44 number, and then the potential risk for death greater than 1.32. I put these up to legitimize our concern by fairly good numbers that have been derived from fairly well-developed studies that inform us that why we must be careful. And this is, again, as a repeat of the data I showed you earlier, the risk of using opiates. Now we use a lot of urine drug screening. I prefer to use point of care because if there's a problem with my patient, I like to know it when they're in the office, and I can approach them at that time. If I tell them to go to the lab, then it's not really a random urine drug screen, is it? It's they know when they're going to the lab. Also, you can't necessarily talk to them because you don't get a test result back for a couple of days, and you lose that moment in time. We have our system set up to store these results, allow us a quick and easy look, and you can see some people can actually present some problems as we're trying to help them with their issues. In addition to the overdose deaths, we also have a spread of immunodeficiency disease. This was collected in Massachusetts from January to May 2018, and this is an increase in the number of HIV/AIDS diagnoses. And so opiates put you at risk for developing HIV/AIDS if you feel compelled or you're in a position where the only way you can get help is to go out and find a needle and a syringe and give yourself an injection. Likewise, the use of benzodiazepines in addition to opiates is It's painfully obvious that this is a significant problem for us as well. And this has resulted in in many states, especially the state of California, issuing us a number of guidelines that we need to consider with every patient coming in. Also, when these risks appear, it reminds us that we need to make sure we tell the patient, I'm also going to call in a naltrexone spray or nasal spray for you in the event you overdose. Now, what good that is for the patient who is overdosed, I'm not sure. It's a much better discussion to have with the person who is taking the opiates and their loved one. So if they find them subdued, they can then get the next naltrexone sprayer and take care of that patient. But you can see here, anybody who's taking more than 90 morphine milligram equivalents per day, history of opiate substance use disorder, history of obstructive sleep apnea, and concomitant use of sedative sleep hypnotics. My rule is anybody who gets who I'm going to give more than 30 tablets of any opiate of any dose, including Tylenol with codeine, I'm going to put in a prescription for a naltrexone sprayer. Naltrexone nasal sprays do not require a prescription. They can be obtained over the counter. But if I put it in as a prescription, I then have an indelible note in my chart that says, I not only recommended this, but I called it into the pharmacy to have the pharmacy recommend it to the patient as well. Other predisposing health concerns. We talked about sleep apnea, that's usually related to obesity, anxiety, or depression. You're likely to treat with a benzodiazepine. Fibromyalgia, these people tend to want to take more medicine because the medicine does not necessarily work that well. And both in men and women, low testosterone can be exacerbated, or normal testosterone can be made lower by chronic opioid use, even chronic opioid use under the direction of your doctor. So if you're currently on chronic opioids and your doctor hasn't checked a testosterone in years, it's a good thing to have them add on to the list. Other health concerns, in recent years, they've talked about dual diagnosis treatment centers for opioid use disorders and other substance use disorders. These dual diagnosis centers, it kind of surprised me because I thought everybody was working off the dual diagnosis, because if you tend to become a substance misuser, then clearly there's some underpinning disturbance that's causing you to take that type of chance with your life. So this is a list of the things that we typically would look at and try to treat and or refer out to psychiatry once an appointment might become available. And then finally, what do we do when chronic pain therapy becomes noticeable substance use disorder? Well, we doctors now are trained, and our residents are trained to recognize what multiple substance use disorders look like. This is the DSM-5 for what opioid use disorder looks like. You can read, hopefully you can see this pretty well. You can read 1 through 9. 10 and 11 are interesting because I really only give them half a point. To be taking medicine and to be tolerant of it is not necessarily a sign of addiction. Certainly, if you were taking so much that you were addicted, you would be tolerant. And likewise, because of the tolerance, if you were to stop this medication abruptly, you were on vacation, you ran out, the drug company didn't tell you that they were out of stock, because of the tolerance, you would have withdrawals. So do not use tolerance and withdrawal alone to make a diagnosis of substance use disorder. If we find that a patient meets the classification for substance use disorder above, for the last 20 years, the FDA and DEA, along with Redken Bernkeys, are the makers of Suboxone, also known as buprenorphine and buprenorphine and naloxone, have made it possible for primary care doctors to take an 8-hour training course to get what's called a DATA 2000 waiver and to be able to prescribe buprenorphine or buprenorphine and naloxone for the treatment of opioid use disorder. This has been a tremendous boon to a number of patients who either would not otherwise have been able to have gotten into a rehab facility, although in recent years that's become a little bit, it's become a little bit easier. But now we can provide this particular medication to get them off of the other opiates that they were abusing. And also allow them the opportunity to simultaneously see an addiction counselor, a therapist, a psychologist, or a psychiatrist to help try to understand what else is going on. Certainly probably the most popular is these are the films. These can also be cut, and patients seem to tolerate this overall well. A few patients have complained about the taste. Other patients prefer the tablets. The tablets aren't so easy to cut. They kind of crumble. Nonetheless, they now we're finding are a little bit cheaper. This is Sublocade. And Sublocade is the new liquid depot form of buprenorphine for those patients that either their mood fluctuates as to their willingness to take medication or they forget to take it. For being provided an injection of Sublocade puts us in their system for 30 days. We currently are working on developing the policy for administering that here at Eisenhower. And this drawing here sort of shows what this depot form does. It's a subcutaneous injection under the skin that's slowly released over the course of 30 days. It is very expensive, but many insurance companies are paying for it because it's cheaper than risking the further development of HIV/AIDS or potentially death by injecting a bad form of heroin. The Butrans patch releases a slightly lower amount, so we don't typically use this as much for addiction. Nonetheless, it can be used for pain. Now, buprenorphine has only been approved by the FDA for pain. Has only been approved by the FDA for addiction treatment. But because it binds to the mu receptor, it can also be used for the treatment of, it also works for the treatment of pain, and it works about as well, it seems to work about as well as Dilaudid. The efficacy can vary, and that of course gives it a morphine milligram equivalent of about 2 to 3. I've seen other schedules that have even placed it higher. Nonetheless, it is not approved, so it is off-label usage. But the Butrans patch is designed to handle that, and you can see what the dosages are here for this particular type of medicine. This is the buccal medicine, and by buccal I mean this is what you would stick to the inside of your cheek, and the various doses. This isn't this slide turned out differently than it looked originally. But you can see the doses go from 75 mics on up to 900 micrograms. And this again is primarily for pain management. Many patients taken the highest dose up to twice a day, perhaps some even higher. But this is slightly more expensive. Nonetheless, it does not have it has a much safer biochemical profile than the traditional opiates have. So the medications that we use for treating opioid substance use disorder, once we identify that, are buprenorphine, naltrexone, and these come in various forms: pill form, film form, a transdermal patch, and a buccal patch. Methadone, which while any doctor can write for methadone for pain, you can only get methadone at a methadone center for pain. And then Vivitrol. Vivitrol is an injectable form of naloxone, or naltrexone rather. Naltrexone can also be given as a 50 milligram pill, but the Vivitrol is a depot form of naltrexone. And so for those patients, once you've had the patients off of opiates and transitioned to buprenorphine, and they want to come off the buprenorphine, but they're still a little nervous, you can put them on the Vivitrol, and the Vivitrol will prevent, if they decide to, that they want, if they get to urge to relapse and inject themselves with heroin, or if they take they go back to prescription medications, those will not be able to release the dopamine that they did before, because the Vivitrol will be blocking their ability to bind to those receptors. So the biochemical significance of this is displayed here. You can see this is what a full agonist looks like when you get one-to-one binding. This is what a partial agonist looks like when you get not quite one-to-one. And then naltrexone, the full agonist, we see down here where there's, I'm sorry, this is a full antagonist down here. So there's no dopamine release. There's minimal dopamine release and none down here at all. So buprenorphine is a great middle of the road product that patients tolerate very well. And once on this for 6 months or longer, they lose most of their craving. This MAT is medication assisted treatment. And this looks at the reduction of heroin deaths over the course of 1995 to 2009 with regard to or how it has affected heroin overdoses by being able to use buprenorphine, the small dashes down here, and methadone, which you see up here. So by getting these patients converted on these products, they were no longer taking the heroin, and we were able to positively impact that number of lives. So the major features of buprenorphine that make it such a good medicine are it's a partial agonist, it's long acting, and it doesn't have the respiratory depression that the other opiates have. It's got a higher affinity and it has very slow dissociation. So we've covered how opiates work. We talked about how they should be used, the risk of using opiates, and when therapy becomes a disorder. And I thank you for your time, and I'm available for questions as you may have them.
Great, thank you so much, Doctor. Really appreciate it. The presentation is very thorough and helpful as always. Feel free to ask some questions. I don't see anything in the chat yet, but you can unmute yourself if you'd like, or you can raise your hand or do a chat question if you would like us to ask it for you. Anyone? Jill? Put Jill on the spot.
Those, in addition to the substance use, I talked briefly about the many issues that can lead up to that, and certainly the persecution that we see in the LGBT communities that oftentimes lead people to seek desperate approaches to trying to calm the storm. The Suboxone has offered a way back for a number of that population to become healthy again. And so while I may have focused on the use of opiates in initially the beginning of treatment of pain, a lot of people who just go directly to abuse for whatever reason, the ability of a good primary care doctor to start at least a psychiatric treatment in addition to treating the substance use disorder can help restore, I think, normal physiology and improved health in a shorter period of time, and be doing that all in the same visits. While many psychiatrists are privileged to offer buprenorphine, many don't. And while many pain doctors may do a little bit of buprenorphine, most don't do true addiction treatment. And as I mentioned earlier, we have a new addiction fellowship starting, and they will be located in Cathedral City, so be looking for their advertisements. I would hope that we would continue to be the clinic of choice out here in the eastern end of the valley from La Quinta and points eastward for those patients so afflicted by substance use disorder in general. We have the capacity for taking care of alcohol use disorder as well as tobacco use disorder. Those methodologies are also fairly established. So see your doctor and get the help if you need it, or recommend a doctor to your friends that you think need it.
Great, doctor, we do have a question saying, what medicine is used to help with the pain of fibromyalgia?
So the pain of fibromyalgia is historically, they've used, they've relied upon antidepressants, primarily serotonin, but they found that the SSRIs, in conjunction with the norepinephrine inhibitors, were initially a better way to go. And so they did that. And then the next drug, so the first drug approved for fibromyalgia was Cymbalta, and then the second drug was Lyrica. And Lyrica is we call it a GABAergic. It binds to the GABA receptors, and GABA plays a very definitive role in pain management. But none of these are 100%. And I think there's still, we're still waiting for somebody to come up with something a little more definitive with, why is it substance P just seems to float around and not be behaving itself, and why aren't we looking at ways to deliver and manage that? But early on, you can ask any doctor, and we all hate seeing patients in pain. And this whole thing with pain has frustrated a lot of doctors. So most doctors don't like treating it. And, short of saying, here's 2 aspirin and call a pain management specialist in the morning. But since we're here training doctors, I try to at least make sure that they're exposed to the basics of this. So they, if nothing else, they should be able to recognize if their patient's being properly treated for pain, if they're being properly managed for pain. And if they show up and it's clear that they aren't being properly managed, that the physicians we trained will be able to make good, educated recommendations for what their continued treatment should be. But in my idealistic viewing of the doctor of tomorrow, it's we should be able to treat most any substance use disorder the same way we treat a sore throat.
Another question is for someone who is, say a perpetual or lifelong kind of addicted to pain meds and that, and masking, potentially underlying health concerns. How does somebody like that meet with their physician, and how do they even have that dialogue to meet with a physician to figure out the path to figure out what is that underlying cause?
Well, the opening question, it's always nothing makes a doctor happier than to have a patient come in and say, doctor, I'm tired of taking these opiates. I don't want to be in pain, but I'm tired of taking these opiates. Is there a plan B? What can you do to help me? And that excites a doctor. The thing that depresses a doctor is to have a patient come to you on 240 milligrams of oxycodone a day and say, doctor, I need more pain medicine. And it's like, well, you're not going to get that here. So the patient should instigate that dialogue and say, hey, I'm just tired of taking these pain medications. I'm tired of being, if it's constipated all the time, or the older I get, I'm a little more foggy of thought, or my doctor never checks anything. And I just went and seen that my testosterone's been at 0 for the last 3 years and nobody's taking care of that for me. I want to get off of this, then, and then the beginning steps are essentially to taper down, and it's to go slow and go low and go slow. So tapering on the order of 10%, and there's no, that's not fixed in stone anywhere, but usually if you go more, if you go to 25% or more, people get a little jittery and they're always they're expecting to feel withdrawals no matter how little you bring them off. And so you don't want them to become unsettled biochemically. And so that's always the challenge. And then if everybody was willing at the outset to come down off the opiates and then they change their mind, I try to buy for a little more time, because it can take several months at that first lower dose for the patient to really feel comfortable. But in the meantime, we can always add traditional things like clonidine and the like to make them more comfortable in coming down off this medication. The other more dramatic approach would be to say, okay, I want you to consider this. Tomorrow morning, you will take your last oxycodone, or yesterday, tomorrow morning, you'll take your last oxycodone. Then I want you to come to my office the next morning after that, pick up a prescription, or have somebody pick it up for you. Go out to the pharmacy, pick up your buprenorphine, and then come back to my office. If they've never had buprenorphine before, I'd have them come back to my office. And then we would do an induction. An induction is we give them one of the films under the tongue. We would take their vital signs. We would measure we get a withdrawal scale reading. It's called a COWS, Clinical Opioid Withdrawal Score. And we see that, okay, they're maybe a 13 or an 18, and okay, yeah, we can see you're uncomfortable, and so we might give them 2 milligrams of buprenorphine under the tongue, and within a half hour we take the numbers again and we see they've already started to come down. Patient reports that they're feeling better. We give them another 2 milligrams under the tongue, another half hour, and now they're feeling like almost normal. And then we give them another several milligrams to take up until midnight that night. And then the next day we say, okay, put a whole film in your mouth and cut this one up and take this throughout the day. And then on the fourth day, they do the same thing. They take 2 whole films, cut the third one up. And then on the next day, they just take 3 films and we leave them there and have them follow up within 7 days. And it's become all the rage now to do inductions at home. So you come into my office, I look you over, we agree you have no injection sites that have become infected. So I don't have to do any infectious disease work. We will go ahead and check people out we'll do an STI screening on patients when they come in, because substance use disorder is as much a contributor to STI as anything else. And so we're able to make sure as primary care doctors, we're able to do that all in one setting. And then after we get that squared away, then we can check your blood pressure and we can check your lipids and do all the other routine stuff as part of that. So we've been quite successful at transitioning people, and we've had a number of very dramatic success stories. Helping one young patient get from the streets to a master's degree in English, and that type of success. This is one of the most gratifying things I've done in healthcare.
That's amazing. Thank you very much. Other questions from anyone? I know we're just a little over the time, but is there any last minute questions so we can have the doctor answer?
All right. Thank you very much for your time.
Thank you very much, Doctor. Thank you for your time. Thank you, everybody, and we'll see you in a week or so for the next lecture.